We are live.
Good evening. Welcome to yet another episode of Walk-in series, where we discuss practical clinical situations with presentation and expert discussion. Today we have a theme on child with poor vision, SQUINT and NYSTAGMUS, how to diagnose and manage and when to refer. Just before we go on to the webinar itself, I just want to remind all the viewers that we have a brand new One AIOS YouTube channel on which you can have the entire content of AIOS at one particular location. This will include content from scientific committee, ARC, etc., and also from the webinars that we have conducted in the past. In this YouTube channel, we have already about 1,400 videos lined up for you to watch whenever you want. Today's webinar will be chaired by our President, Dr. Harbans Lal, and Professor Pradeep Sharma, who is the former professor of Happy Center, AIMS, and currently Director of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology, Center for Sight, New Delhi. Moderators are Dr. Manoj Mathur, who is the Honorary Treasurer of AIOS, and effectively it will be moderated by Dr. Savleen Kaur, who is the Assistant Professor, Advanced Eye Center, PGI, Chandigarh. Our expert panel consists of Dr. K.S. Santangopal, who is the past president of AIOS and also an experienced strabismologist, works in Bangalore. Professor Pramod Kumar Pandey, Honorary Secretary of SPOCI and former Director of GNEC, Maulana Azad Medical College, New Delhi. And President-elect of SPOCI, Dr. Shubhangi Bhave, who is a consultant ophthalmologist and a pediatric ophthalmology specialist at Drishti Eye Clinic, Nagpur. We also have Dr. Elizabeth Joseph, who is Chief of Pediatric Ophthalmology and Strabismus, Little Flower Hospital, Angamali, Kerala, and Professor Dr. Rohit Saxena from Happy Center, New Delhi. Our speakers are very talented and diverse. Dr. Ramesh Kikunaya begins with a talk on infant with poor visual response. He's the Director of Child Eye Institute, LV Prasad Eye Institute, Hyderabad. He'll be followed by Dr. Ankita Bisani, who's the Chief of Pediatric Ophthalmology, Arvind Eye Hospital, Chennai. She speaks on a child with esotropia. Sumita Agarkar, who's the Deputy Director of Shankar Netralaya, Chennai, and Chief of Pediatric Ophthalmology, speaks on a child with exotropia. She'll be followed by Dr. Jitendra Jethani, who's the Director of Baroda Children's Eye Care and SQUINT Clinic, Baroda. He speaks on a child with congenital nystagmus. And Professor Pradeep Sharma speaks on a child with progressive myopia. Dr. Subhash Dadia, Professor of Ophthalmology of GNEC, New Delhi, Maulana Azad Medical College, speaks on a child with amblyopia. I hand you over to Dr. Savleen Kaur for the proceedings.
Thank you so much, Dr. Santosh. A very good evening to all of you. Today we have an excellent webinar organized by AIOS to evaluate, diagnose, treat a child who has poor vision, SQUINT, and nystagmus, and when to refer these children. With an excellent lineup of speakers, we start off today's webinar with Dr. Ramesh Kikunaya. If I can request him to share his screen. He would be speaking on an infant who has a poor visual response.
Thank you so much, Savleen, and thank you, Dr. Santosh and the AIOS team. I'll be talking about infant with poor vision, why my baby can't see, what, why, and how. Basically, most of the infants has to be referred to a specialist. There are some situations, probably depending upon the expertise of the person, can be managed. So infant visual assessment is a little bit different from pediatric. That means, toddler and juvenile children's vision assessment. Just very little of milestones we should know. What happens at birth, what happens at 2 to 3 months of age, as the child recognizes the mother. And then 3 to 4 months is a good time where the child starts fixing and following light. And then 6 months, the child tries to explore when the child has neck holding. So these are some of the very, very important. There are much more details to it, but we need to know. But children and infants, sometimes older children, they come with a different package. You will have to examine in different situations. You might have to go out of your routine examination technique to get at least a glimpse of some of the visual response of the child. As in this case, you might have to completely darken the room, and then you can see the fixation is not very steady, and you can elicit in the dark room, when you throw a light, you can see nystagmus coming. So this is subtle signs that what you're dealing with some of these patients. Don't expect, to look into the details of spontaneous venous pulsation and things like that. It's difficult. Some of the techniques where you can use for the fundus photography, but sometimes you just have a glance, whether with that you have to say whether there is a pseudo disc edema or a true disc edema. So situation is like this, this infant, I'm going to show some case. The child is 9 months old, still neck holding is not there, because when you assess a child with infant with any kind of eye problem, you're not looking just at the vision, you're looking at eye motility, you're looking at general health, you're looking at developmental milestone, you're also looking at the response. What is happening? Child is comfortable with the mother's lap, but you can see the sporadic fixation. There are some subtle developmental milestones like social smile is there. In spite of 9 or 10 months, there is no neck holding. Similar situation here. The child is a little bit older. I'm showing because it's not that infant is the only thing we'll be seeing, but there will be a combination of things. That's why you need to know a little bit older children, what are the response. Trying to see with so much damage in the brain, because this damage has happened prenatally, not postnatally. That's why the child is okay. So the differential diagnosis of poor vision in babies we'll discuss. And one of the most important cause for poor vision in infants is cerebral visual impairment. And I'll just touch upon how to approach the diagnosis. So clues for abnormal vision, even if you don't know anything, lack of fixation behavior, searching eye movements, nystagmus, and strabismus tells there is a poor visual maturation in an infant. With this picture, with one glance, the child on the left side has a very good visual response. You don't have to do a teler-acuity chart. You don't have to do anything. But if you look at the video on the right side, there is no fixation at all. But if you look carefully with the torchlight, there is a cataract there with nystagmus, with searching eye movements. So picking up this normal and abnormal visual behavior in a bilaterally blind patient is a bit easy. You have to have some kind of bright toys or some light or some kind of fixation target is what you need to have to assess the vision in an infant. I'm again talking about diagnostic point of view, what you need. Refractive error can be very high and low in these cases, but again, the response will be very poor. One of the important things as an ophthalmologist or eye care professionals we need to have is the ability to do a Bruckner's reflex or a red reflex. That tells a lot about most of these kids, because as an ophthalmologist, if we can rule out in the first examination most of the anterior segment diseases and also posterior segment diseases, you can come to a fairly narrow differential diagnosis. Again, look at this patient with high hypermetropia. Visual behavior looks very good. What I'm holding a very small toy, which is very attractive, and that itself is enough. Probably you might have to use your thumb as an occluder to see whether there is any preference. Again, we have enough other tests like teler-acuity, Lia paddles and things like that, but This should be more than enough. Look at this child. You can definitely see this both eyes total cataract there with very, very poor visual response. And the lower video is after the cataract surgery. Still there is an abnormal head posture. Even with that, the child is able to see. I'm showing these videos just to show how you can pick up these things. So anterior and posterior segment anomalies, which are listed here, I think it's pretty easy to pick up with the comprehensive examination of the anterior segment and also the posterior segment. And always remember, in an infant vision assessment and the strabismus or eye movement assessment goes hand in hand. It's not like, okay, I've done the vision assessment, let me do a strabismus or let me do a nystagmus evaluation. Everything goes at one go. So some of the differential diagnoses like congenital stationary night blindness, it does not happen completely in infant, but we can get some of the patients. Decreased vision in dim elevation. The child is very uncomfortable. They will have nystagmus and myopia will be there. Leber's congenital amaurosis is one of the very commonly referred patients with infants with poor vision. They have this typical oculodigital sign. They don't have nystagmus. They have nystagmoid movement, and they have an inophthalmos, and they have a poor vision. Most of the times what happens is they get 2 or 3 MRIs before they come to an ophthalmologist. Mainly, it's not a cerebral visual impairment. It's an ocular visual impairment because of the retinal dystrophy. Albinism, again, that's why I said vision assessment, eye movement assessment, and strabismus assessment. All 3 in one, you can do it in these infants. And obviously, remember to check the external appearance, look for any dysmorphism. Everything happens in one glance in children. Excuse me. So, after the comprehensive evaluation, you will know whether there is a coloboma, whether there is a morning glory syndrome. All that is possible. And sometimes everything will be normal and the child will have just a delayed maturation. Anterior segment normal, no strabismus, no nystagmus, posterior segment is normal, no refractive error, high refractive error, then probably you are dealing with a case of delayed visual maturation. This is again a 9-month-old infant with microcephaly, low birth weight, seizures, visual inattention, no nystagmus, mild temporal pallor, normal anterior segment and the pupils. And on the scan, you can see in the occipital area, there is an infarct. This is hypoxic ischemic encephalopathy or PVL, or call it as mostly a cerebral visual impairment and sometimes cortical visual impairment, but the correct terminology is cerebral visual impairment. This way, you have ruled out all the ocular causes and mainly its posterior segment. Again, the clue is if some children come to you with normal development, infant with good tone of the muscle, looking here and there, but except there is a poor visual response. Mostly it is LCA. But if they have eventful birth like hypoxia, seizures, microcephaly, global development delay with ocular, vision development delay, it's mostly a cerebral visual impairment. You will get, if you do the MRI scan of these patients, they will have hardly some tissue brain available depending upon the severity of this CVI. I'm just going to show some of the images because these are all the possible things what you see in cerebral visual impairment. Disturbance of vision caused by defective function of retrochiasmatic part of visual system in the absence of important ocular disease. Again, I will not go into the details of CVI. This is another talk, but you should know what is ventral and what is dorsal. Where is the problem in the dorsal as well as in the ventral? And also, what are the top causes for this problem in children? Most of them are caused by perinatal hypoxia. Seizures, cerebral palsy, and microcephaly is the most common associated problems they have, and they can also have varied esotropia and exotropia. Visual rehabilitation, child rehabilitation is the most important. It has to be multi-systemic, not one way. You have to do a lot of behavioral characteristic changes in children with this, and you need to work them probably for many years to get the good development in that. So last 3 slides, which is telling, this is directly taken from Mike Brodsky's textbook on pediatric neuro-ophthalmology. Apparently blind infant, just check whether there is infantile nystagmus or no. If there is nystagmus, think about anterior visual pathway disease, either optic nerve or retina. These are the 2 things you can have. You can also get other tests like MRI, ERG, which will really help which way you are going. History, examination, looking for infantile nystagmus, mostly it is anterior visual pathway. If there is no nystagmus, good vestibular ocular reflexes, which is normal, there is prematurity, then you are thinking mostly about the cerebral visual impairment in these patients. Having said that, some of the CVI patients also can have nystagmus. So this is the flow chart showing how do you differentiate apparently blind. I'm sure showing this flow chart because the anterior segment and the posterior segment is normal, except in the last few cases, it can be abnormal. Even LCA in an infant can have a normal fundus. So these are some of the investigations you can do immediately to get the answer for a poor visual response in an infant. That's why, because of this multi-system involvement, most of these infants has to be referred to a pediatric ophthalmologist in 90 to 95% of the cases, because some of the things like CVI and all that is an ophthalmic emergency where you can start a rehabilitation process. So in conclusion, suspected poor vision in infant is a challenging situation. Remember the pointers to poor vision. I would again reiterate meticulous history is as important as examination. To look for specific etiological clues. And of course, once you diagnose, and sometimes even to diagnose, a team approach is very, very important. Thank you so much.
Thank you so much, Dr. Ramesh. That was indeed an exhaustive review of how to approach a child who has low vision. You gave us some important pointers as how an exhaustive history and examination can be done before, even if we do not have any sophisticated and relatively expensive test to check the visual acuity, a detailed history, and of course, an systemic as well as an ocular examination can actually help us come to some conclusion as to this child has poor vision. While Dr. Ankita loads her presentation, if I can have one comment or anything that our chairpersons or the panel likes to add on.
I think
Dr.
it was
Ankita?
a wonderful talk by Dr. Ramesh. I would just like to add that we may, nowadays we have that CVI manual, which is very diligently produced by Dr. Niranjan Pahere. I think we should make use of that. It gives us detailed things about the CVI management. So it's a really difficult task and most places may not have that facility. But yes, we need to see that these cases are sent to the right place.
Thank you, sir. Dr. Ankita would now be speaking on how to approach a child with esotropia.
So, with a very wonderful start, I will start with my topic, which is a child with esotropia and walk-in patient series. Not able to go to the next slide.
Just click on the screen. Just click on the screen.
Yes. So I have nil financial disclosures. The objective of my presentation is to understand the main categories of esotropia, a practical approach to patient presenting with esotropia, to categorize urgent and non-urgent referrals for esotropia, and to discuss the treatment options for a practicing ophthalmologist. So whenever a walk-in patient with esotropia is encountered, multiple questions occurs in the minds of a practicing ophthalmologist. Instead, a simple approach with history taking, examination, investigation, and treatment would clinch to a diagnosis and begin at least initial management. So here is a child who presented, a 5-year-old child who presented, to us who was referred to us with esotropia. But the corneal reflex was central in both the eyes and extraocular movements were within normal limits. Is this really esotropia? No, it is actually pseudo-esotropia, which is an optical illusion due to facial architecture. No squint noted to corneal reflex. These are commonly encountered with children with small interpupillary distance, wide nasal bridge or larger epicanthal folds, and resolves as the nasal bridge grows. Also, transient esotropia is very normal up to 3 months of age, as RK sir had pointed out, that fixation usually begins after 3 months of age. So, as any strabismus, we have to first understand the onset and duration of esotropia. Any perinatal injury, also common among esotropia. Family history of esotropia has to be noted. Developmental delay is commonly associated with esotropia, and a family album tomography will help us to understand the onset and the progression of esotropia. If there is an acute onset, then of course the other history like double vision, headache and asthenopia, history of viral illness and recent vaccination, head trauma, and excessive near work should also be noted. On examination, as with any ophthalmic case, visual acuity and cycloplegic refraction has to be done. In some cases, stronger cycloplegics may be needed, for example, in esotropia less than 5 years of age or in later hypertropia. Here's another 1-year-old child who was referred to us with esotropia since 6 months of age. The child was not fixing and following in right eye with 30 degrees of esotropia. Anterior segment examination shows a congenital cataract. As RK sir has already pointed out, anterior segment examination is very important. Even media opacities like cataract, corneal scars, or other cause of unilateral loss of vision in less than 4 years of age will usually present with esotropia. Similarly, a posterior segment evaluation is also important to complete the evaluation. In a walk-in clinic, we can actually do basic squint evaluation. We can do a head posture. A corneal reflex can easily be done, and extraocular movements can be evaluated. Ductions, to emphasize on ductions, this has to be checked. And a doll's eye head maneuver will help for an uncooperative child. Fixation preference can easily be checked in a walk-in clinic, and diplopia charting, if diplopia is present, can also be done. Broadly, esotropias are classified into committant and incommittant esotropias, which has accommodative and a non-accommodative type. Accommodative are usually refractive, non-refractive accommodative, and partially accommodative. In non-accommodative, there are infantile esotropia, non-accommodative convergence excess esotropias, and acquired esotropias. So a 5-year-old presented to us with 35 prism diopters of esotropia for near and 40 prism diopters for, 35 for distance and 40 for near. Uncorrected visual acuity was 6/60 in right eye and 6/36 in left eye. A cycloplegic refraction showed high hyperopia. So this was nothing but an accommodative esotropia. So the characteristic of a refractive accommodative are high hyperopia, usually more than +4 diopters. Distant angle is usually equal to the near angle. A normal AC/E ratio. With full correction, there is little or no residual ET. the characteristic of non-refractive accommodative or moderate hyperopia, emetropia, or myopia can also be encountered in these cases. Distant angle is usually less than near angle. There is a high AC by ratio, and full correction is obtained only with bifocals. So here is a case where with in a refractive accommodative, where we just connected with hyperopic lenses and the esotropia was completely corrected, and a non-refractive accommodative where bifocals had corrected the esotropia. To elaborate a little more on spectacle corrections, any degree of esotropia is there, then a full cycloplegic refraction with full correction should be given. So according to the AAO guidelines, even if the age is less than 1 year, about 1.5 diopters of hyperopia should be corrected in less than 1 year of age, and above 1 year of age, even a minimal 1 plus 1 diopters of hyperopia should be corrected. Bifocal lenses, usually executive bifocals are used, and the bifocal line should bisect the child's pupil. Otherwise, it will not correct the ET. The characteristic of an infantile esotropia will be large angle, a cross fixation. So where the child uses the eye to see the ipsilateral eye to see the temporal fields of the opposite side, and vice versa. Latent nystagmus, dissociated vertical deviation, inferior oblique overaction, a mild or moderate amblyopia, non-significant hyperopia. Usually it is initially managed with spectacles and patching therapy and referred for surgical correction to a pediatric ophthalmologist. Amblyopia management is required, like patching is required in any case with preset amblyopia, or if there is a fixation preference, alternating eye patching might be advised to patients to prevent fixation preference and thus prevent amblyopia in some cases. Vision therapy are also indicated to improve amblyopia and binocularity. There is always controversy whether infantile esotropia have to be operated early or late. The advantages of early surgery would be better stereopsis and DSV and reduce post-op DVD. The advantages of late surgery would be better accuracy in estimating the angle of deviation, possibility in correcting vertical misalignment in same sitting, and treatment of amblyopia pre-op. Another child, a 10-year-old child, presented to us with sudden onset of diplopia. There was a history of prolonged usage of mobile. The visual acuity was 6.6, unaided, and esotropia was concomitant with full extraocular movements. So this was diagnosed as basic type of acquired non-accommodative esotropias. Acquired non-accommodative esotropias usually present with sudden onset of concomitant esotropia with diplopia. The commonly encountered type under this subheading would be the basic type, which usually occurs in children more than 6 months of age. The risk factor could be a prolonged usage of near device, and if present with neurological symptoms, they have to be neuroimaged. The divergence insufficiency type usually presents in older age group, and this can be secondary to pontine tumors or raised ICT. A spasm of near reflex, which is nothing but ciliary spasm, which presents usually with pseudomyopia, can also present with esotropia and related to psychological factors such as stress and anxiety, usually treated with cycloplegics, hyperopic corrections, and counseling. Neuroimaging is very important in any acute onset esotropia to rule out any underlying intracranial disease. The treatment options could be conservative treatment or Botox injections. If nothing works, then surgery is the final outcome. So in any incomitant strabismus, a forced duction test can easily be done, and it can help. If it is an unrestricted on abduction, then a diagnosis of 6th nerve palsy can be made. If it is restricted on abduction, then mechanical restrictive conditions can be thought of, or it could be DRS. There is always a confusion between congenital 6th nerve palsy and DRS, but congenital 6th nerve palsy usually presents with very large angles, and there will be no palpable fissure changes, enophthalmos or shoots, which is commonly encountered in DRS with smaller angles. So to conclude, the treatment options in a walk-in clinic could be which are non-surgical, could be the refractive error corrections with monofocals or bifocals, depending on the diagnosis, amblyopia therapy, and further management. It can be referred to a pediatric ophthalmologist. Indications for referral and red flags would be suspected esotropia, where the diagnosis is not sure, any abnormal red reflex, any acute onset esotropia, any esotropia with neurological symptoms which may need imaging and referral to a neurologist, and esotropia with other ocular abnormalities. So pearls would be correction of refractive error is the first step of management of any strabismus. Amblyopia has to be identified and to be addressed at the earliest. Neuroimaging is very important in any acute onset esotropia. Identifying the type of esotropia is important to plan appropriate management for each case. Thank you.
Thank you so much, Dr. Ankita. Any questions or comments for Dr. Ankita? Ma'am, you're muted. We can't hear you, Dr. Elizabeth. These days, we see a lot of acquired and non-accommodative esotropia. Dr. Ankita, do you recommend, because we have general ophthalmologists also listening to this presentation, we do take a detailed history of mobile phone use these days, and do you recommend neuroimaging for these cases?
Ma'am, actually, usually we don't directly fall to neuroimaging. We can actually, if there is no other neurological symptoms, then it can be observed for some time. We can try Botox, and neuroimaging could be done only in cases where there is some symptoms like headache, nausea, vomiting, or something. Then it has to be done. Otherwise, these cases we generally don't do a neuroimaging.
I think Dr. Sumita is now ready with her presentation. Thank you so much, Dr. Ankita. We now have a presentation on child with exotropia by Dr. Sumita. She's the Deputy Director at Pediatric Ophthalmology and Adult Strabismus Services at Shankar Nethralaya, Chennai. Welcome, Dr. Sumita. All yours.
Thank you to Dr. Santosh, Dr. Savleen, and for AIOS for giving me this opportunity. Am I audible? Because my internet is a bit unstable in the some time back.
Loud and clear.
Thank you. So why we need to talk about exotropia? Because it's far more prevalent in Asian countries, including India, compared to esotropia, which is what is reported in the literature, in Western literature. It appears seemingly straightforward, yet can be frustrating to manage. And there is more divergence about divergent squint than anything else in the ophthalmology. And etiology can be very, very diverse and very problematic at times. And we still have gap in knowledge regarding natural history and best treatment modalities for this. Our failures are probably maximum in this entity than any other strabismus entity as far as surgery is concerned. So to know the enemy, exotropia in simple words is defined as an outward deviation of the eyes, and if very broadly classified into two groups, committant and incomittant, and my screen shows the way it is classified, and all of these entities can walk even in a child. Some of them you do see more in adults, but any of them can appear in your clinic. So just to give an example of each of them, this is a 4-year-old child who has a 6 months constant squint since birth, 6 months since 6 months of age, visual acuity equal and good in both the eyes, but has craniofacial anomaly along with it. And you can see a large left exotropia clearly seen here and a little bit of a V pattern. Now there is another child who this is the child looking at a distance in the picture on here and looking at a near object, and you can see there is a intermittent exotropia this child has, which is more manifested for distance compared to near, means she has good control for near and poor control. This is the most common entity which we are going to see as far as exotropia is concerned. Then you can have something called a sensory exotropia. This child was brought to the hospital. She is just about 9 months old, and parents noticed the squint. And of course, when on comprehensive eye examination, he had a cataract in the left eye. Eye is myopic as well as amblyopic and has cataract. So this child's exotropia is purely sensory in nature or secondary to the poor vision. This lady is probably had a squint correction done, both eyes, no old records, but has a now large exotropia. You can see telltale signs of surgery on the medial rectus on both eyes, and you can. So this probably will classify as consecutive exotropia. This is a 9-gaze picture, and as you can see, there is a little limitation and telltale signs of previous surgery here. This is an 8-year-old who has come to me with drooping of eyes and outward deviation, visual acuity again 6/6 in both the eyes, And this is his 9-gauge picture. Again, you can see there is ptosis and there is limitation of movements, a classical congenital third nerve palsy, again presenting with exotropia, which parents notice. This again is a 13-year-old who has come to me with squinting of the left eye, limited adduction, a really prominent upshoot here, exotropia in the primary gaze. And of course, this girl has a Duane syndrome with exotropia. So as you can see, another patient who has come to me with exotropia following a surgery for FES, surgery for sinus surgery, and again, large exotropia with limited adduction. And MRI shows a breach in the medial orbital wall with medial rectus transection. FDT at this point is negative, but this also could be what we call as a paretic or a concomitant exotropia. So irrespective of what are the types of exotropia, you can have, your workup should include, especially in a child, visual acuity with an age-appropriate chart. Sensory, some authors put it as like sensory evaluation should be done before you do even a cover test. But if it is not practical, you can do it in any order. But motor evaluation basically consists of cover test, measurements, and looking at the motility. No exotropia evaluation is complete without a fundus evaluation as well as cycloplegic refraction. So comprehensive eye checkup is required for any strabismus entity, and more so in children with exotropia. So yes, sometimes how to diagnose, diagnostic, there is no diagnostic dilemma here. It's very clear that she has a very large exotropia, but sometimes, as you can see with this girl here, you can see strabismus is not so evident at this point when we do the cover test, but she has a exophoria. And as we prolong the cover on one eye, you can see a clear drift. And over a period of time, by doing the repeated cover test, you can see now she has broken into an intermittent divergent squint. Now it's a tropia, and she's not able to control it anymore because you have artificially, by doing a repeated cover test, we have broken her fusional response, or we have suspended her fusional response. So this is how sometimes a very typical intermittent exotropia can come. And you can see now she has actually atropia, which straight eyes, which started with phoria and then ended up with tropia. However, there is a small entity here, which is called pseudoexotropia, admittedly very rare, but it's an appearance of exotropia because of a very large positive angle kappa. In this picture, if you see, I don't have the cover test pictures of this girl, but as you can see, it appears as if she has left exotropia, but she doesn't, because on cover test, she is orthophoric, and it is because of, very commonly because of macular ectopia. And you may see in children who have had prematurity or retinopathy of prematurity, leading to a temporal displacement of the macula. Now, motor evaluation in these children, that's the most important step, and it is all about assessing control of strabismus and measurements. So control can be assessed subjectively, objectively, and there are some very good control scales are also available, which we can look up in the literature. But measurements, at least near and distance, must be done. If it's an intermittent squint, probably recommended to do a far distance one also, and side gazes. And especially if you're looking at concomitant squint, probably all important gazes must be measured. So measurements can be what we call as simultaneous prism cover test, which takes care of a manifest exotropia. You go on increasing the prisms while keeping the cover at the same time as prism. And when there is no movement, that can be considered as your endpoint or measurement. While as in alternate prism cover test, you go on increasing the magnitude. You alternately place cover and prism, and you go on increasing the prism till you don't get any movement or anything. So this usually gives you total deviation, while as simultaneous prism and cover test gives you manifest tropia. Near distance disparity should be checked, and this man is responsible for most of our knowledge about disparity, where if there is a large difference between the angles for near and distance, you must follow it up measurements with a monocular patching. And if that near distance disparity persists despite patching, then you must measure it with a 3D lens, 3 diopter lens plus 3 diopter lens to see for any high AC by ratio. So very short video here. As you can see, this lady has a good control. She has a fairly poor control for distance, but you are not able to see any squint for the near. So she has a large squint for distance, but the same thing when you check her with a near angle, you can see a very small squint. And what should we do in these cases? You patch her for an hour and make sure that other eye is not allowed. There is no binocular stimulation in between when you are opening the patch. And as you can see, her angles have built up to almost same as what you were measuring, and the same thing. So this takes care of most of your near distance disparity. This is an easy test. And before planning, if you do get a large difference between the near and distance angle, must be done. So how do you deal with these children? So correction of refractive error is a very important step. Clearance of media opacities, if there is any. Observation, you can observe small angle, well-controlled IDS. There is no need to jump into surgery or an intervention if it's a control is very good. Sometimes you can give an alternate occlusion, although in children, cooperation is a little issue, but it does help in improving the control. Sometimes over minus glasses are given, although there is a large study in the recently have proved that over minus therapy can sometimes lead to a myopia. So a little bit cautious in younger children with over minus glasses. And orthoptic exercises, of course, can be prescribed in slightly older children and in young adults, and prisms as a temporizing method. So as you can see, this child who had dilated, this is a surgery, post-surgery. You can see his exotropia also looks better with the glasses, and once the intraocular lens has been put. Now, fusional exercises, again, they improve your diplopia awareness as well as they train your fusional mechanisms to control your strabismus. Basically, you're training your own muscles. Not very effective in children. In my experience, it doesn't work very well in young children, and I don't give it. But in older children and adults, young adults sometimes can be used. As I said, over minus glasses up to 1 to 2 diopter can be prescribed. Usually symmetrically, should be given symmetrically. Very useful in younger children if they have poor control. But watch out for esotropia or worse esotropia, because that can lead to amblyopia. And as I mentioned earlier, a small possibility. Small angle strabismus prisms can be tried, both ground in prisms as well as Fresnel. They give relief from diplopia, but again, more or less a temporary method in large angle squints. Now, surgical intervention, if you see a poor control or squinting more than 50% of the waking hours or constant squint, these are my indications for planning surgery. And of course, if the patients ask for it, and parents do often take that decision for us in several issues. So all of these are your indications for surgery. So you have to worry about target angles, timing, and choice of procedure. So if it is well-controlled IDS, better to defer surgery in very young children till you have reliable measurements. Otherwise, between 3 to 7 years is a good age to operate if exotropia is not well-controlled or larger in magnitude. Target angles in patients who are fusers and who have good binocular potential, 5 to 10 prisms of overcorrection is desirable. However, beware of overcorrection in very young children, because sometimes this overcorrection, which is more than 5 to 10 prisms with a poor binocular function, can lead to these children becoming not only monofixators, but also amblyopes. In adults, it's better to stick to orthophoria as your end target. And in myopic children, sometimes it's better to really modify your surgery a little towards undercorrection in high myopes. Again, there is a whole lot of controversy about unilateral versus bilateral surgeries, but it may be also influenced by the type of exotropia. If it's a basic exotropia where near and distance are same, RNR works equally well as a bilateral lateral rectus recession. Near distance disparity may also play an important role if your near angles are a little more than distance, you would like to do a medial rectus recession rather than doing a bilateral surgery. And pattern deviation must be addressed in your surgical plan. So this child, again, with a slight amount of constant right exotropia, she also has a little bit of craniosynostosis and a little facial asymmetry, as you can see. And here I went ahead with doing only a right and R&R surgery in the right eye. And as you can see, you've got a good alignment. The child which I showed earlier with a large constant exotropia with a V pattern, she had equal vision and not really a very fixation preference. So, and I wanted to correct the V pattern. So I went ahead in this patient with a bilateral lateral rectus recession with the inferior oblique weakening with a fairly good alignment post-op. This child has third nerve palsy, as I had shown in that earlier picture. And as you can see, even though he has adduction limitation here, but he is able to adduct from this to almost up to midline. He is able to adduct a little beyond midline. So in this, I went ahead with a little a large R&R in the right eye. And as you can see, it has given a fairly good cosmetic correction, not a very great improvement in the depression or elevation, but adduction looks a little bit better. This child again had a V pattern and large exotropia. So since I wanted to correct a V pattern here, I went ahead with bilateral lateral rectus recession, and I also tackled obliques in the same time. And as you can see, at least on the day one, he looks good. This is my girl with Duane syndrome. She had a very large upshoot and relatively small angle exotropia, and I did only a lateral rectus recession with a Y split. And you can see her upshoot looks better here. Still has a small residual exotropia, but overall fairly satisfactory outcome. Now I'm talking about overcorrection because this was supposed to be a child exotropia with a child with exotropia. Now overcorrection in adults, just last 2 slides. The overcorrection in children is a little dangerous because you can put them at risk of amblyopia and lazy eye. So if it does happen, watch it very closely. Make sure that better eye is preferred eye is occluded. If there is any hyperopic correction which you have left uncorrected, correct it, and prisms, and probably have a little less tolerance for surgery and do it a little early. So when to refer or worry or investigate in a child with exotropia? If any exotropia which is associated with unexplained poor vision, you must worry. Look at optic nerve carefully, look at CVI carefully. Any exotropia associated with acquired motility limitation also need worry and investigation. Post-trauma, post-surgery, any exotropia which is acquired in these situations also need a little bit of referral and multidisciplinary approach. So this is a 35-year-old. This is my last slide. 35-year-old complains of redness. He has come to redness and no other complaint about diplopia. Only on guided questions he's saying diplopia. And he has a very small exotropia in the right eye, but vision is 6/18 in the right eye and 6/6 and 6. He has no complaints about vision. There is a mild restriction of elevation, but rest is full. On careful examination, there is a trace RAPD. Now he tells me that he has had a evaluation for a military service, and at that time his vision was 6/6. So that's how we ended up with doing an MRI in this patient, and there was a circumscribed oval lesion extending up to the cavernous sinus and nerve sheath tumor, suspected nerve sheath tumor, disappeared for follow-up, never came back for follow-up. Did come for allergic conjunctivitis in the emergency 2 times without doing any further evaluation. So there are reasons why some of those exotropes you need to worry and evaluate, and more so in children in whom you cannot explain poor vision, as exotropia very rarely gives rise to amblyopia, and you should not explain away any poor vision in a child with exotropia. Reverse is true. Poor vision can lead to exotropia, but exotropia leading to poor vision is relatively rare, and make that as diagnosis of exclusion and not really the first thing which you think. Thank you very much for your attention.
Thank you, Dr. Sumita. indeed an exhaustive review, and the take home is that exotropia with low vision, I think that is what we need to pay attention to and maybe refer if a general ophthalmologist wants to discuss. Dr. Shubhangi, any comment or?
I just wanted to ask Samita about cases of consecutive esotropia. You have a case of consecutive esotropia. Many you must be having over so many years.
Yes.
Do you follow them up? What do you find? How do they respond? Or what is the ultimate, what do you need? How many percentage you need to reoperate? Or
A lot of them actually do become better over a period of time. As I said, up to 5 to 10 prisms, probably you don't need to worry, especially if child has fairly okay binocular vision prior to surgery. Their fusional responses are going to take over, and if they have enough fusional potential, most of them will become better. I would be very suspicious of, I would be very wary if it is more than 15 prisms. I would be very wary of even producing a 15 prism in a 3-year-old, because that can actually be more harmful than the original large intermittent divergence. 40 prisms of intermittent exo is probably better than 10 prisms of ESO, constant ESO. So my question is this question is a bit can be answered at 2 levels. Yes, older children, probably you can watch up to 15 prisms. If it doesn't go away in 6 weeks, I do move forward with the rest of the steps which I said. I will go give the hyperopic correction. I might even add a small prism, which a lot of these times I've been able to withdraw the prisms over a period of time, because once they start becoming straight over a period of time. But I would be very wary of overcorrection in child who is under 5, definitely. Even if it is a small overcorrection. I would watch it every 2 weeks.
Thank you, ma'am. I would request Dr. Jitendra to upload his presentation and share. Sir, quickly we can take a comment. We're just a little bit behind. Dr. Santhan wanted to say something.
Yeah, I have one question. How often do you see you're so concerned about amblyopia at the age of 3 years in a child operating for exotropia? How often do you see amblyopia developing at the age of 5 years after esotropia develops?
I have seen, that's why I'm talking with personal experience.
Yes.
Okay. But in the literature, you don't find many cases of amblyopia following exotropia surgery at the age of, say, 3 or between 3 and 5.
Sir, I'm talking about persistent overcorrection. If I don't think we wait for it to amblyopia to develop and then do something about it. We know any small microtropias. If you are going to convert an intermittent divergent squint into a microesotropia, I don't think you are doing a child a favor.
Exactly, because that will be some amount of binocular vision.
Yeah, that is an unsatisfactory outcome. Why should you worry only about the vision?
So somehow I feel that the children less than 7, I would never have a desire and overcorrection at all. I would rather have an undercorrection and do the second surgery later on. Exactly. Less than 7, I would never overcorrect. 7 to 14, maybe overcorrection up to 8 to 10 prisms. More than 10 prisms usually are going to be problem even for older children and adults.
Exactly.
Thank you, sir. Dr. Jitendra is now ready with his presentation. He'll be talking about congenital nystagmus.
Yeah, thank you so much, Dr. Savlin. Thank you, Dr. Santosh sir, for letting me speak on congenital nystagmus, when to refer, and what to examine. So we will start with what exactly is nystagmus. Nystagmus, we all know that it is defined as a rhythmic oscillation of eyes. This is just a small video. We all know that the underlying defect basically appears to be a disturbed feedback to the gaze centers from the proprioceptive receptors, which are in the periphery, which interfere with the control of fixation mechanism. The fixation is basically the visual system's ability to detect retinal image drift and program the corrective eye movement. So that is what actually moves the nystagmus also. That is what moves the corrective eye movement, is actually the fast phase. We will see how it happens. And the suppression of these unwanted saccades that would take the eye off the target basically prevents nystagmus in all of us. The direction, this is what, whenever a patient of nystagmus comes, we should see which is the fast phase, whether it is horizontal or vertical fast phase, whether it is pendular or jerk, velocity, amplitude. These are some little bit of signs that we can use. We can make a grid of 9 gazes. I'm not going into a lot of details of documentation, but little bit documentation should be done. We should try to look for a null zone. And if I know there's very paucity. There are very few people who have ENG, and the slow waveforms, the slow phase has to be seen, whether it is accelerating or decelerating. Mainly because most of the classification of nystagmus, which is now there, is on the basis of electronystagmogram. This is an important point. We should all, this is very important from life-saving point of view and from the diagnosis point of view. All these points which I have written are basically in the congenital nystagmus, whether it could be in good old days, they used to classify it as sensory and motor nystagmus, which has been now taken over by fusion maldevelopment nystagmus and idiopathic or infantile nystagmus syndrome based on electronystagmography. Congenital nystagmus would be more commonly bilateral, more commonly of equal amplitude, predominantly in a single plane, jerky, pendular. There will be a null zone or a neutral zone. There could be a latent component. It would be absent in sleep. There could be associated head movements. Oscillopsia will be rare, and it dampens with convergence. When you see the nystagmus, when you tell the patient to look on the right side, it would start beating on the right. When you tell the patient to look on the left, it will start beating on the left. So all these things are important. When you have a patient of congenital nystagmus, you have to first differentiate whether it is actually a congenital nystagmus or a pathological or acquired nystagmus, which you have to refer. Now we come to the broad classification. Now the old congenital motor nystagmus is now the infantile nystagmus syndrome. The clinical features, the nystagmus features, there could be a null zone, it could be jerk, pendular, it could be combined. Most important is that the slow phase will have an increasing velocity waveform. This is the characteristic differential or differentiating feature between infantile nystagmus syndrome and the fusion maldevelopment nystagmus. The visual acuity may be very good, and the fixation or the expanded nystagmus function may be high. And this is a typical fusion maldevelopment nystagmus. The latent nystagmus is present. So the latent nystagmus is basically, it starts beating on toward the fixing eye when one of the eye is covered. The fast phase is toward the side of fixing eye. There is a defect in cortical motion processing, that results from lack of development very early. So if there is a, if it is associated with a congenital strabismus, there may be a lack of development of binocular vision, and that may relate with the defect in cortical motion processing. And there is an imbalance in subcortical optocondylar OKN systems. So this will have an exponentially decreasing velocity waveforms. We will see how to interpret these waveforms very shortly in a brief manner. So these are some of the things which could be seen. There could be a neurologically absolutely normal kid with visual sensory abnormality. There could be a neurologically and visual sensory normal and still may have nystagmus. The kid may be neurologically abnormal, but there would be a static encephalopathy, just like in Joubert syndrome or cortical visual impairment commonly seen in periventricular leukomalacia or hypoxic ischemic damage, like you see the ventricles are dilated here. Or there could be neurologically abnormal with a progressive neurodegenerative disease or a metabolic disease. So this is the whole gamut of nystagmus. Then there is a small subclassification of nystagmus blockage syndrome, which actually shows accelerating slow phases. There would be esotropia without nystagmus on visual attention, and orthotropia with nystagmus on visual inattention. This is what I was talking about. Just very briefly, we will see what is electronystagmogram. So this is basically, we all know there is a continuous electrical processes in the retina. And this is how you put the electrodes. And if we look at, these are the schematic drawings of the waveform. So this is the slow phase, this is the fast phase. So typically by convention, right means up and left means down. So you can see that this is the accelerating, this is the slow phase. The longer line is slow phase, and then there is a sudden dip. So that when the dip is from up to down, it means that it is left beating nystagmus. And the slow phase is basically an accelerating slow phase. So this is congenital motor nystagmus. And likewise, we will see. So what are the goals of management? The goal of actual management is to increase the visual acuity. Now we can do it with reduction of intensity of nystagmus, decreasing the slow phase velocities, increasing fovation periods, or with abnormal head posture. Non-surgical treatment is not very commonly seen, but glasses are the most effective intervention that can be given. So we have to do a cycloplegic refraction. Brinzolamide eye drops have been used by Deloso and Hertel, and in some of the patients it does work. Prisms, not very practical, but can be used in some patients where they are not fit for surgery, or they can be used to induce convergence. I'm not much experience with prisms because I have never really used such large prisms. Baclofen or carbazepine can reduce nystagmus. A role of brinzolamide has been seen, and in some of the patients you can use that. So we come to the major aspect of management, that would be surgical management. So first and foremost is, before we embark on doing a surgical management, we should measure the patient on several visits. This is a chrome which is used to measure the head tilt, chin elevation, and face turn. We should recheck the patient several times before we are pretty sure that there is no periodic alternation. We should see the patient for both near and distance. So this is how we are measuring the face turn, chin elevation, and the head tilt. And so face turns can be of two types. They could be conjugate and they could be disconjugate. When they are conjugate, there can be a presence of strabismus or absence of strabismus. If there is presence of strabismus with this patient, when the patient is looking towards right, the eyes are toward the left, so the null zone is on the left side. Straight flush, it works for 15 to 20 degrees, 5, 6, 7, 8, 5, 6, 7, and 8. And in presence of strabismus, we have to determine the preferred eye for fixation, calculate appropriate dosage of surgery on that eye to center the null zone, and then calculate appropriate dosage on the fellow eye to center the zone and adjust for the tropia. So it is the preferred eye which will be operated for nystagmus, and the non-preferred eye for the rest of the part which has strabismus. Now this is the same slide. And for CNCR form of nystagmus or disconjugate, we have to do a bimedial recession, which will center the null zone and also will correct the esotropia. So pretty straightforward there. If there's a chin up position, we have to move both eyes upwards. If there's a chin down position, we have to move both eyes downwards, whether we can do superior rectus recession of both eyes with inferior rectus resection, or we can use infraoblique. This is just a small video of one of the patients which we operated for head tilt. We can even do surgeries for head tilt. For head tilt, we have to move the eyes towards the null zone. So if there's a right head tilt, the eyes are moving toward the left. So right eye is actually intorting and left eye is extorting. So we have to move the eyes. We have to tilt the eyes toward the right side. So that's this is the patient. This was this is the post-op. And this is the pre-op, this thing, and this is the post-op. And in summary, we have to, when the patient presents to us, we have to record the pattern, the type, the plane. We have to do the refraction, cycloplegic refraction, and we have to document if there is any problem with the fundus evaluation or if the disc has any abnormality. And we have to do a neuroimaging. We have to, differentiate whether it is congenital or pathological, glasses, and brinzolamide eye drops. If there is a face turn, appropriate amount of surgery can give good results. So thank you so much. I hope I was on time.
That was actually too much on time. So any question from the chairpersons of the panel? How frequently do you give brinzolamide drops, sir? And what is your experience and a follow-up with drops like?
So for me, I give brinzolamide eye drops to quite a few patients, and basically what I do is I measure the visual acuity, tell them that they can use these drops, come back again after 3 weeks, And if they feel that it is doing something for them, because I don't have an electronystagmogram. If you have an electronystagmogram, it is pretty easy. Maybe you can pick it up. But otherwise, I don't think I would continue it for a long time if there is no result. I think Dr. Sharma sir has done some study. There was a thesis at RP Center, or I think with Dr. Rohit.
Yeah.
So we did this on brinzolamide. I would suggest that you should treat a patient for at least 3 months, because the effect starts actually significantly after a month. Patients with face turn surgery is the better intervention. You could theoretically get a statistically significant improvement in vision in our study, but many patients were satisfied, some weren't. So it's a good try in patients with nystagmus without a head posture, and a good percentage of them, at least initially for a period of time, do feel satisfied. So we had a few patients who post-study also were interested to continue with the drug. Again, on electronystagmography, we were able to demonstrate that there was an improvement in the waveform. But again, more than the electronystagmography, it was, a few patients were satisfied, some weren't. So you could give it a try, especially in those who don't have a face turn, because you really don't have too much to, offer them.
I have myself tried in many patients, but I didn't feel there was any response with the brinzolamide. So should we continue it for a longer time and see? I try for a month or so, and then if it doesn't, so I stop it.
I think there are some patients who are very, they come back and they're seriously into it. They at least those patients motivate you to continue in other patients also, because there are some patients who they really want. They tell that there is a marked improvement. I don't know whether it is their psychology which is playing into it or not, but because I don't have an electronystagmogram. But some patients are really good believers, and as Dr. Rohit said, they want to really continue it.
Thank you so much, Dr. Jitendra. We now move on to our next presentation, that is a child with progressive myopia, which is now a pandemic in itself, and it's a hot topic for discussion, and 15 minutes would be less for that, but I am sure Dr. Pradeep has all his experiences to share. Sir, all yours.
Thank you, Savlene. I would like to thank Dr. Santosh for giving me a topic which otherwise I would not have been speaking on. I would have chosen to be speaking on any of the earlier topics. I have no financial disclosure except that I've been an expert for the Essilor Stellest. We are talking of myopia, as Savlene said, it's becoming a pandemic. The prevalence of myopia varies from various population surveys from 0.8 to 75%. There are large racial and ethnic variations which are there, and the Asian populations, particularly the Southeast Asian and the Chinese populations, have much more. Myopia may be associated with increased risk of a lot of eye problems, which we have to be concerned about. Now, these are the side effects of myopia, and they become exponentially more if the power of myopia is increased. As we can see in this table, the risk of myopic macular degeneration is almost 40 times in -6 to -9 diopters, retinal detachment 21.5, and if it is lessened by, let's say, by 3 diopters, the risk can be reduced by 1/4 or 1/3. And if they can contain it to low myopias, then the risk is very negligible, or as much as for a normal person. So these are the benefits of controlling myopia that we have to be thinking about. As we can see, the reduction of even a 1 diopter of myopia can be reducing the myopic maculopathy by 40%, retinal detachment by 23%, and even open-angle glaucomas and other problems can be reduced. So what are the signs of myopia in a kid? They may come with eye strain or headaches, squeezing their eyes. I think this is used in English language as squinting, which we nowadays use for another reason. The squint would be for us eye deviation, but they tend to squeeze their eyes or make the aperture narrow to see better. Usually they come closer to the objects. So if they are not able to see from far away, and especially nowadays, many a times these children are referred by the school teachers that the child could not see from the blackboard from distance. And when they rotate the children in their classroom, they are picked up. They tend to move closer to the TV. The disturbing trend is that there is a myopia progression. And this all over the world, it is rising from in 2020, whatever the levels were there, it's gone up almost like double, and it may go up to 50% of the global population having myopia. What are the causes? The factors mainly are ethnicity and the parental history. These two things probably we cannot do much about, but we can probably change the factors in the optical or the near work activities or time spent outdoors. The age of onset is very critical. Myopia onset at 7 years of age, the progression rate is 0.90 diopters per year. Myopia onset at 12 years of age can have the progression of 0.3 diopters per year. So if we can have the children picked up early, if they have any myopia, we would save them from having a high myopia. According to the COMET study, 50% of children's myopia tends to stabilize by age 15 and 75% by age 18. The role of near work is to be understood. It is very, and that's the reason why it's becoming pandemic in these times, when the children are more and more doing a lot of near work, and especially the digital screens tend to create more problem because they are more addictive than other near tasks. So how can we control? We can correct the myopia, but remember, under correction, as it was prevalent in the past years, has found to be having a more rapid progression of myopia. So you need to correct them optimally. And still, can we do the management? Yes. So what are the intervention measures that we have been trying for the last few decades? One is the use of spectacle lenses in the form of progressive lenses, bifocals, peripheral defocus lenses in the like DIMS and the Hall lenses. Contact lenses have been tried, multifocal, extended depth focus, dual focus contact lenses, as well as orthokeratology. And in the pharmaceuticals, the low dose atropine has come to our rescue in a big way. Summary of the ATOM studies from Singapore show that this low dose atropine is something which has been very helpful. They started with atropine 1%, then 0.5%, and now they have come that even 0.01% has found to be having a reduction in myopia progression to an extent of about 0.71 diopter in 2 years. This is a summary of these two studies, which are landmark studies, the ATOM1 and ATOM2, which have shown consistently that low dose atropine of 0.01% even is effective in controlling the myopia progression. Similarly, the LAMP study, the low concentration atropine for myopia progression done at Hong Kong, has also confirmed these findings, although they have suggested that 0.05% atropine is the more optimal concentration to be used. Even from India, a study done, a multicentric trial published by Dr. Rohit Saxena, has shown that in a year's time, a 54% reduction in the spherical error progression was seen with even 0.01%. Similarly, an Australian study, the West Australia study, ATOM study, has also confirmed these findings. The PEDIG study from US somehow has not confirmed these, and the reason given by Michael Repka is that it could be a variation of the ethnic population that they had chosen in this group. There were less Asian and more African American who have otherwise also less progression. The mechanism of action for low dose atropine is non-accommodative. It is not by having a cycloplegic effect, but we do not know for sure what and how it works, but it is seemingly working probably through a neurochemical cascade on the non-muscarinic M1, M4 receptors at the retina, or maybe directly on the scleral fibroblasts. And it may be through a dopamine release, which has been found to be there. And as we can see that outdoor activity has more dopamine, which is probably the way it works. This could be another way of substantiating this hypothesis. The meta-analysis have shown that AL elongation was significantly lower even with 0.01% atropine. And although 0.05% was comparable with the higher doses of atropine. The pupil size and accommodation amplitude were dose related, more so with 0.05 than with the 0.01%. The other means of controlling myopia is optimizing the optical correction of myopia. As we know that the way we treat myopia, usually with the spectacles, it has a peripheral hyperopic focus. But the reverse has been shown in animals to be having a peripheral myopic defocus to be controlling myopia progression. In the award-winning lecture by Dr. Earl Smith 3, this has been shown and published. The special spectacles, we are talking of now special designs. One is the defocus incorporated multiple segments by as known in short as DIMS. Now, this is 1.03 millimeter diameter lens slits, which are sparing the central 9 millimeters, and they are in a honeycomb appearance in the 33 millimeters. Similarly, there is a HAL, or the highly aspherical lens slit target technology, which creates a volume of myopic defocus or a white shell in front of the retina by 11 concentric rings. If you see comparison of these two mechanisms are having aspherical lens slits in concentric configuration, and the other one is in the honeycomb configuration. The DIMS study of 2-year results showed that 52% less spherical error equivalent was seen to be reduced, and AL elongation, the axial length elongation by 62% with the DIMS lenses. Similarly, the HALT published the 24-month or 2-year clinical trial in which they had shown 67% efficacy in the spherical error in diopters and 60% in terms of axial length by the usage of these spectacles, which have been worn at least 12 hours per day. The study has been now extended to 3 years, and these 36 months trial results are now available, and they further substantiate that the myopia progression has been reduced by 1.06 diopters in 3 years' time. And similarly, the axial length has been also changed by 0.49 millimeters compared to the single vision lenses. So these are the comparison of the spectacle lenses. As you can see, the earlier used progressive additional lenses or bifocals were not much of much help, but there has been a significant effect by either the DIMS or the highly aspherical lens slit technology. What are the adverse effects of these visual functions? We can see that there is a contrast acuity effect and also a peripheral motion perception which have been studied. Fortunately, they are not much affected in the peripheral vision of these children. The effect on binocular functions is another thing that we need to be aware of in children. And we know that there is a reduction in accommodation. So by spectacles and the contact lenses, there is an exophoric shift. Whereas using cycloplegic drops, even like 0.05% can have an isophoric shift. So be aware of this. The summary of this is that we do have these things available. So what do we do? So we have the myopia control strategies available in the form of either spectacles or orthokeratology, which has its own problems, and the atropine in the form of 0.05. But in India, we have only a 0.01% atropine available. So what do? We emphasize, first of all, the daylight outdoor activity in any child having myopia. We need to emphasize that a minimum of 2 hours per day or 14 hours a week is found to be effective in at least delaying the myopia, even if not having an effect on the control of progressive myopia. Reduce sustained near activities is very important. The 20-20-20 rule is empirically used, but studies have shown that 30 minutes, giving a break after 30 minutes of at least 1 or 2 minutes is found to be having a better effect, and sustained near activity should be curtailed. We should talk to these parents if the myopia is progressive. So, and then also emphasize the need of compliance whenever whatever measure we are going to use. We may choose one or more if the risk is more, and the refraction should always be done under cycloplegia. What are the risk factors? We do use this sheet usually for the explaining to the parents. First of all, the factors we need to understand the current age. If the child is of younger age, the risk is higher, as we had talked about earlier. If both parents are myopic, again, the risk is higher. If the time spent outdoors is less than 1.5 hours, again, the risk is going to be more. If the near works time spent is more, it's than 3 hours, again, the risk is more. If the refractive error at the presentation time, the first time that we are seeing is going to be there at 6-7 years of age. So younger people, and they are having a higher progression of myopia. Contrast this with the lower risk with the other children. So if we have these children having a risk of higher myopia, we need to first document progression. Never start atropine treatment or spectacles in a child just having myopia unless you have documented in at least 6-month progression has been seen. Because I feel otherwise we would be getting credit for the medicines which otherwise would not have been progressing otherwise on its own. Special attention to younger children with high myopia and other risk factors such as family history or pathological myopia should be taken into account. If there is a higher risk, then higher dosage could be considered at the beginning of the treatment. The good thing is that children can tolerate higher doses better than older children, and because their amplitude for accommodation is higher. So these children, even with 0.05%, would be having less of problems compared to the adults who may have better off with the 0.01%. We should also tell the parents about non-responders. It's important that we tell them about the compliance. I usually tell them the analogy of guarding the border. If you guard it 23 hours but sleep in 1 hour, you would lose the effect altogether. So we need to be very diligent in using either the atropine or the glasses, which have been recommended to be used in 12 hours per day. When we are going to stop, we should be tapering and never stop the medicine abruptly, because we know that there is a rebound effect. And we should taper it by using a lesser concentration, or later on by using less days in a week. Recently, I have come across that there are now newer mechanisms in children, particularly because putting a drop is a challenge. So these OptiJet or a micropine thing is a dispenser, which would be probably available in future. They inject micro doses, and they are even going to be nicely taken up by the children. There is a nice prevention management children progressive myopia national consensus guidelines published in IGO. You can go into for more details. So that would be my talk on this for this purpose. We can have discussion if there are any points. Thank you, Dr. Sabli.
Thank you so much, sir. It was indeed an exhaustive review of all treatment modalities that we have, stressing on the fact that pharmacotherapy is at present the most agreed to upon modality for myopia progression. And we have atropine 0.01 that is commercially available. Any comments by the panel, Dr. Pandey, Dr. Elizabeth?
See, am I audible now?
Yes, ma'am, you are.
Yeah. So, sir, that was an that was an exhaustive presentation on prevention of progression of myopia. I fully agree with everything. One thing I would like to add is that by preventing the progression, we are giving them a chance for LASIK surgery. That also is also important. We are preventing preventing the complication, but as the child grows up, if the myopia is controlled, they can go ahead for a LASIK. That also is important.
A better point of view. We now have Dr. Subhash Tadia. He would be talking about a child with amblyopia. And Dr. Subhash sir is Director Professor at Department of Ophthalmology, Guru Nanak Eye Center. Dr. Subhash sir, please.
Sabli, my slides are visible?
I can see your slides, sir. Yes.
Yes.
So, very good evening to one and all. At the outset, I want to thank AIUS and particularly Dr. Santosh for inviting me to speak. And I would also like to thank all the panelists. I will be speaking on how to diagnose and manage and when to refer a child with amblyopia. So basically, first step is what is amblyopia. So amblyopia is derived from Greek word, which means dull vision. And clinically, it is defined as unilateral or bilateral reduction in best corrected central visual acuity, which is caused by found vision deprivation and are abnormal binocular interaction during critical period of visual development without any visible organic cause. The visual acuity should be less than 612 for bilateral amblyopia, and there should be difference of 2 or more lines for unilateral amblyopia, and it is correctable if appropriate measures are applied at appropriate time. Basically, in pathophysiology, development of various visual functions depends on 3 fundamental conditions. First, adequate stimulus from each eye. Secondly, corresponding retinal images. And thirdly, integrity of visual pathway. Many neurological, physiological, and psychological aspects of amblyopia are still not fully understood. What are the main alterations in amblyopia? There is deprivation of visual stimuli, that is due to ptosis, cataract, or nystagmus. Alteration of sharpness of visual stimuli with refractive changes, that is high ametropia or anisometropia, and non-corresponding images received by each eye, that is due to strabismus. So why amblyopia should be treated? Because it leads to restricted career options, reduced quality of life, less social contact, cosmetic distress, low self-esteem, visual disorientation, and fear of loss of vision in other eye. So what are the clues for amblyopia? It is a significant health problem. Early detection is critical for success. If a child is having fixation preference, there is tilting of head, rubbing of eyes, abnormally high blink rate, resistance for occlusion of the sound eye, drifting of eye when child is tired and sick, closure of one eye in sunlight, and child is looking close to very closely, and if there is presence of amblyogenic factors, then we must look for and rule out amblyopia in these patients. Then who are the patients who are at risk? Unilateral amblyopia is associated with strabismus and more in esotropes as compared to esotropes. If there is high refractive error, if hypermetropia is of more than 3.5 diopter, astigmatism of more than 1.5 diopter, you must suspect amblyopia. If there is presence of microtopia and small angle isodeviations are there, you must rule out amblyopia. Presence of unilateral cataract, congenital cataract, ptosis or other media opacities, they have high amblyogenic tendencies. Bilateral cataracts with opacities. If there is family history of amblyopia and squint, if there is premature baby, and if there is delayed neurological and visual maturation of unclear etiology, these are the patients who are at risk for development of amblyopia. In amblyopia, we must note down the age of onset, interval between onset and presentation, history of prior treatment. Education and motivation of the parents is the most important factor. Visual acuity, refraction, glass prescription, fundus examination, fixation preference, and presence of nystagmus. However, it is not uncommon to see getting clinicians puzzled over a case of diminution of vision, whether it is functional amblyopia or otherwise. And for diagnosis of amblyopia, there must be reduction of the visual acuity, there must be presence of amblyogenic factors, and there should not be any organic cause for reduction of visual acuity. Until and unless these three conditions are there, you should not label a patient as amblyopic, and carry home message is complete ocular examination is mandatory before a patient is labeled as amblyopic. What are the various clinical features? Decrease in the visual acuity is the hallmark for amblyopia. If there is defective stereo acuity, it necessitates further investigation for amblyopia. Fixation preference for one eye suggests amblyopia in preverbal children, and it remains one of the most valuable clinical method for diagnosis of amblyopia. Crowding phenomena is very important in cases of amblyopia. The effect of neutral density filters, the vision might improve in amblyopic eye with neutral density filters. Usually in dense amblyopia, color vision defects might be seen, contrast sensitivity is defective, visual fields are also lost, there is reduced reading speed of the child, there is compromised fine motor skills, accommodation may be defective, RAPD is occasionally present, and eccentric fixation is present in many patients, and macular thickness may be affected on OCT, and functional MRI can detect cortical defects in amblyopia. However, amblyopia remains one of the most confused entity in ophthalmology. We have to test the visual acuity on age-appropriate basis, that is for infants, preferential looking VEP, OKN, and for preverbal children, preferential looking VEP, picture charts, Landau C chart, Taylor acuity card, and older children's Snellen charts. So, for diagnosis of amblyopia in preverbal children, fixation preference is one of the most important thing, and grading acuity can be determined using Taylor acuity cards. However, these have drawbacks. They are time consuming, require expertise, and underestimate amblyopia. Bruckner's reflex is very important, and it is done using the direct ophthalmoscope, and it is simple and useful to diagnose ametropia and anomalies of eye at an early age. Then you must see, is child looking well, developmentally normal, any structural defect, any head postures. Then what are the visual goals to be achieved? Identify the children at risk, diagnose the amblyopia at the earliest, identify the etiology of amblyopia, inform the family about the disease, start the treatment at earliest, limit the effect of amblyopia on quality of life, employment, and career options, re-evaluate the patient, and revise treatment as and when necessary. It is our duty to diagnose amblyopia at the earliest so that treatment can be started. Then what are the questions that needs to be answered? What are the prerequisites? Patients at risk, need for refractive correction, when to start amblyopia therapy, amblyopia PR surgery, treatment options available, patching or penalization, role of medical management, compliance, role of near exercises with occlusion and refractive surgery. So basic strategy in amblyopia is you have to present a clear retinal image to the amblyopic eye by eliminating causes of visual deprivation and correcting visually significant refractive error. Secondly, you have to make the patient to use the amblyopic eye, and you have to observe the patient for any recurrence. Full cycloplegic refractive correction, patching, penalization, pharmacological therapy, refractive surgery, near visual activities in the form of television and mobile games, binocular treatment, and smart glasses are some of the treatment modalities. Classical treatment is refractive correction, patching, penalization, and near activities, and majority of the patients, they will respond to this treatment. For non-compliant and non-responders to the traditional amblyopia treatment, alternative therapies are there like vision therapy, binocular therapy, but there are insufficient evidences to recommend them pharmacological adjuvant to the standard treatment. Although large magnitude of studies have been done, but none of them is foolproof. When to start amblyopia therapy? Start at the earliest. Early detection and treatment are highly cost-effective. Which comes first, amblyopia or surgery? Classical teaching is treatment of amblyopia should be done prior to surgical intervention. Refractive correction is the most important step in treatment of amblyopia, and child's prescription need to be accurate to begin with, has to be changed according to the refractive status, because inadequate refractive correction reduces the treatment efficacy. So proper cycloplegic refraction is must, as have been found in ATS 5 and ATS 7, and ATS 5 was done to evaluate effectiveness of refractive correction in moderate amblyopia, and they concluded amblyopia resolved in 27% of the patients, and improvement of more than 2 lines was seen in 77% patients with refractive correction only. Potentially amblyogenic refractive error has to be kept in mind. Then another question is patching or penalization. It was studied in ATS 1, and they concluded both are appropriate treatment modality for treatment of moderate amblyopia. There is no shortcut or substitute for occlusion in amblyopia therapy. However, variability exists number of hours prescribed to treat amblyopic patients. Then there are various considerations in patching: type of occluder, how many hours, schedule, follow-up, what to look for, how long, and when to stop. Constant total occlusion of the sound eye is the most effective method because it forces the patient to use amblyopic eye. It also inhibits inhibitory impulses arising from the sound eye, and it is best instituted in infancy. But with these pedigree studies, there is choice of part-time occlusion also. There are various occlusion schedules which have been described. Follow-up schedule is 1 week for each year of age. You have to encourage the child for near exercises, and recording of the visual acuity of both eyes with same chart and under similar physical conditions has to be done. Give the child 5 to 10 minutes for acclimatization and not for binocular fixation pattern. We have to see whether there is any improvement or worsening of the vision, if there is any change of vision, change of the pattern, and end point of the therapy is free alteration and equalization of vision. And if there is no improvement in vision after 3 to 6 months of proper occlusion, occlusion failure is defined as if there is no improvement for at least 3 follow-up visits after full-time occlusion. How to maintain the visual acuity after occlusion? You adopt any of the following: part-time occlusion or reduce the visual acuity by atropine penalization. ATS 15 has been done regarding randomized trial of increasing patches of amblyopia, and there is more improvement in visual acuity after 10 weeks compared with 2 hours daily patching. Surgery should be preferably done within 6 months of amblyopia treatment. These are various disadvantages of occlusion, like occlusion amblyopia, functional debilitation, cosmetic blemish. Occlusion amblyopia, it signifies good potential in amblyopic eye. It is cosmetic blemish. In severe amblyopia, especially early in the treatment, it is significant deterrent to good compliance. 1/4 of the successfully treated amblyopic patients, they experience a recurrence within first year of the treatment. Carry home messages: don't stop the occlusion therapy abruptly. Compliance is a very important factor for occlusion treatment. However, monitoring the compliance is a tedious job. Allergic skin reactions can be minimized with use of skin creams. Psychological problems are there, but good parental counseling is need of our prognostic. Various prognostic considerations are there, and good prognostic factors are younger age, good pre-treatment visual acuity, myopic refractive error, additional ear exercises, good compliance, and absence of eccentric fixation. Penalization is indicated in moderate amblyopia in uncooperative patients, anisometropic amblyopia as a maintenance therapy, occlusion failure, allergy to patch and complications of the patch, non-compliant patients, and latent nystagmus with strabismic amblyopia. There is no risk of occlusion amblyopia. It is better tolerated because of comfort and cosmesis. Major disadvantage is potential side effect due to systemic absorption of the drugs. Penalization and occlusion, they have been found to be appropriate modality for initial treatment of amblyopia in cases of PEDIC group of the studies. Daily and weekend atropine has been tried in ATS4. Then this perception learning didactic training has also been tried, but most of these studies, they are lab based and does not find much of the literature on these. Medical treatment, levodopa was supposed to be a promising agent in augmenting the conventional occlusion only, and it is not a primary line of therapy. Various side effects have been found, and in ATS 14, it was not found to be of much use. Near exercises are often prescribed during patching for amblyopia based on assumptions that those activities, they stimulate the visual system. In ATS 6, performing common near activities was found not to improve visual outcome and treatment of amblyopia. However, there are a lot of other studies which are contrary to recommendation of ATS 6, and we routinely recommend near visual activities in the treatment of amblyopia with patching. Then a novel and interesting manner is to associate amblyopia therapy with television game. We have done a study regarding role of television games in amblyopia and published in Journal of Strabismus. And in our study, though ours was a small pilot study, based on our results, we recommend use of near activities in the form of television games along with full-time occlusion in treatment of amblyopia. This in adult anisometropic amblyopia, LASIK has been found to be successful in some patients, but in children, the role is controversial. Mobile games are very popular. They are available in every household. They are a popular mode of entertainment. And now recent concept is loss of binocularity is one of the defining features of amblyopia. So now focus is shifted from monocular interventions to intervention that directly target binocular functions. This has led to increased interest in development of amblyopia treatment that directly address the binocular dysfunction by promoting binocular vision and reducing the inhibitory interactions within the visual cortex. And mobile games as a form of near visual activity, they are useful in treatment of amblyopia. Hess et al. Has found them to be useful. And basically mobile games, they strengthen the fusion and reduces the suppression. So we have also done a thesis, and we recommend mobile game exercises as a form of near visual activities along with 2 hours occlusion in mild amblyopia. Video games have been also tried, but they have not been found to be of much use in ATS 18. Smart glasses patching is the most effective treatment, but has undesirable side effects. The smart glasses have advantage. They are ultra safe, proven efficacy, inbuilt frame of prescription. They are most advanced glasses for programmed intermittent occlusion, but post factor is a limiting factor. Amblyopia with eccentric fixation, role of inverse occlusion is found to be useful. We have found it to be useful in study done at our center. Amblyopia with nystagmus, atropine, penalization has to be done. Unilateral aphakic infants, most researchers seem to favor occluding not more than 50% of the time. And when to refer, the pediatrician should look for cataract, inability to fixate, and any ocular deviation and abnormal eye movements. Such patients should be referred immediately to the ophthalmologist. Other patients which require referral are residual amblyopia, occlusion failure, cases with high refractive error, and patients requiring advanced treatment in the form of squint surgery and refractive surgery. Why there is lack of desired response in amblyopia if treatment has started late, lack of compliance and other associated. So then I would like to conclude optical correction alone is successful in improving the amblyopia in nearly 1/3 of the patient. Patching is the most effective treatment. 2 hours patching for moderate amblyopia and 6 hours patching for severe amblyopia. And patching should be prescribed along with near visual activities. Abrupt stopping of patching has high risk of recurrence. Atropine penalization is as effective as patching. Treatment is most effective up to 7 years of age, and near activities in the form of television and mobile games are beneficial. Smart glasses are areas of future research. Thank you.
Thank you so much, sir, for that elaborate presentation on amblyopia and all the treatment modalities available. We have a question on the YouTube chat, sir, that I would like to request you to answer. That which guidelines do we follow for spectacle prescription in children? Do we follow the American guidelines or the Indian ones?
Guidelines, AIU's guidelines are there, SCOSI guidelines are there.
Yes. So we do have guidelines by the AIOS, and we have published guidelines in the Indian Journal of Ophthalmology, which I think is the most commonly followed guidelines by us. We also have a question, Dr. Pradeep sir. There's a question that how long would we continue 0.01% atropine for?
Okay, so when we are starting at what age, that is important. Right now, we have studies done from Singapore. They are even using in older than 12 years. They have used till about 15 years of age. This has been used. So that is not an issue. At one time, there was a concern that maybe if we are continuing for long, there would be some side effects. Fortunately, that is not being seen. So with the 0.01%, but yes, what we are going to do is, like, if we are starting young, let's say the child is 5 years old and you want to start, you may have to continue and see. You may taper down. Once you have been able to get a control in 2 years' time, then you can taper down the dose. If you are using a higher dose of, let's say, 0.05, you can come down to 0.01% and then use it for a year. And then you can gradually taper. If it's maintained with that, in a probably 2 or 3 years' time, probably you can stop it also, depending on the progression rate of the children. Some children I have seen, in spite of using a 0.01%, they are not responding. We have, in those cases, since we don't have a 0.05%, what I have used is a 10-minute gap and twice in the night time. I do not prefer to use morning and evening dosage because of the possibility of some side effect in the daytime. So I would rather put it in the night time with a gap of 10 minutes so that there is a little double dosing. It may not be as good as 0.05, and we are asking the pharmaceutical companies to get in 0.05% available in India. So those children who are not responding to 0.01, the way to move forward would be 0.05%. Second option is to use glasses along with the atropine. Both are supposed to be working in tandem. So it's not that they are mutually exclusive. So you can add both. So in severe myopes or a high risk, let's say both parents are myopic and they are already having, let's say, 5 diopters of myopia at that early age, then I would probably say that, okay, you can use spectacles as well as the drops. And the concentration you can then see whether the minimum you can start with, and you can see if it's not working, you can go with a higher concentration.
Thank you, sir. So, Rohit sir, what is your opinion on combination treatment modalities for myopia?
So wherever the studies have been done, they've shown the effect to be additive, as pointed out. 0.05 multicentric double-blinded trial is ongoing. So we hope that by January, this study should be out with results. And that is being done for regulatory purposes. So if it comes positive, then we hope that by another 6 months after that, we should be looking for the availability of the drug in the market. Our experience with 0.05 has been fairly good. We've tried them on patients dispensing it from our pharmacy. We tried them in patients with who were non-responsive or poor responders to 0.01. So currently, my modality is that if it is non-responsive or poor responsive, I'll shift from 0.01 to 0.05. And however, if the effect is very poor to start off with, then probably discuss with the patients about shifting to an optical. I would say that in the first go, we should see the effect of an individual intervention before we think in terms of a combination, because if one is not working, there is no point in continuing with that intervention for too long. And obviously, we know that almost up to 30% of children may not be well controlled on 0.01. So 30% may have 0.5 diopters of progression despite being on treatment. So as Sir gave, I think, a wonderful approach to myopia. I think documenting progression before you start therapy is not only important because you need to treat the disease, you need to diagnose that there is progressive myopia and treat that, and not just myopia. the other important thing, as sir has pointed out, is how much is the impact of your intervention. So once you've started on A therapy, and you know that the child was progressing, say 0.75 diopters per year, and your impact has come down, it's 0.5 diopters per year. Now, you know that you have some modest impact. So if it was on low dose 0.01, I would shift him to 0.05. So it's important for us to assess the response to therapy by knowing what the baseline progression was. So, and yes, combination, as I said, has been shown to do well in studies that have been done using combination. We have also in our non-responders seen, but I mean, obviously results are yet to be out for an Indian combination study. We found that, anterior segment reduction of myopia is also there because of low dose atropine, and therefore the results of atropine, low dose atropine, need to be taken with a little bit of, pinch of salt. And that's probably why there was this initial inconcordance between the refractive error reduction in rate and the axial length reduction in rate. So it's very, very important for us to know how much the child was progressing and the impact of atropine, what you're getting.
Thank you. So again, reiterating the importance of documenting progression even once you have started a treatment modality. Another question, Dr. Jitendra, if you're there with us, somebody has asked about congenital nystagmus and amblyopia and role of pardon in some cases.
I didn't get the question. What is the role of pardon in nystagmus?
Yeah, I think it's, so they have said congenital nystagmus and amblyopia. Yeah.
You can do pardon, but the whole problem is that there is a problem with the biofeedback. So doing pardon would reduce the amplitude for some time, but I have never done.
I think internet is unstable. So we have a question.
Yeah, tried by people, but it is not really effective in the long run. Yeah.
So not a very effective treatment. Yeah. Another question. Yeah, please go ahead. I'm so sorry.
Answer that point there. Sablin, can I just answer that point about?
Please, sir.
You don't do pardon for treating amblyopia. You do pardon for treating probably esotropia. That's what he means.
No, the question was for nystagmus.
Nystagmus.
Unless they're asking for Chiantia syndrome, where you have esotropia along with nystagmus, where pardon is indicated along with MR recession. But otherwise, as there is said, that nystagmus not effective, pardons are not effective. All 4 horizontal recti pardons have been described, but essentially not effective.
They are only temporary measures, just like the supramaximal recessions, which would be like equivalent to pardon in a way. They would be reducing the amplitude of nystagmus in the horizontal nystagmus if we do all the 4 horizontal recti supramaximal recessions. So studies done have shown that the effect in those also is only about 3 months. After 3 months, the nystagmography shows the same as it was pre-op. The same is true with the Hertel-Deloso procedures, which we had seen in RP Center, that the effect is only short-lived, just 3 months. So really, we do not have any clear evidence for these 2 technologies.
Thank you, sir. Sumita ma'am, there's a question that exotropia with hyperopia. Do we give a refractive correction, and how long do we follow before going in for surgery, deciding for surgery? We can't hear you actually.
Unmute yourself, Sumita.
Yeah.
Yeah. So hyperopia technically would relax your accommodation and convergence, and exotropia should become more. But if it is a high hyperopia, so up to 2 to 2.5 diopter, probably you can ignore hyperopia. You need not give prescription. But anything about 2 causes visual blur, and that blur itself will cause your exotropia to deteriorate. I'm talking about intermittent. So anything about 2.5 probably needs to be prescribed. Again, you have to consider the age of the patient here. In a toddler, probably you can ignore a little bit more. In a school-going child or a teenager, you may have to give less than that. But it definitely, if anything, which is above 2.5 to 3, again, depending on the age of the child, you probably better to prescribe, because it does clearing the visual blur helps in controlling the strabismus also better. Now, second question is about amblyopia with exotropia. Is that what is
in
the
these cases only? When do you would like to operate? That's the question. Like the question
with
hyperopia.
Yeah. So I think guidelines are same, irrespective of.
I think the question comes.
Yeah, if your angles are little bit more, please remeasure the squints with the. If your hyperopia is say 7, 8 or more, or then probably your prismatic error which is induced by glasses. So it probably is preferable to remeasure those children with a contact lens and accordingly you do, because plus powers do underestimate a little bit of angles. So that's the only difference as far as the surgical plan is concerned, hyperopia or myopia or no error. But apart from that, guidelines remain same. It is not really related to the refractive error. But yes, if you have very high myopia, very high hyperopia, it does changes your angles measurements a bit. So it's always good to remeasure your angles with contact lens or use a table.
Yeah.
Sometimes there are some very effective tables which are given to convert for the vertex distance. So
I think for both high myopia and for hyperopia, we should.
Yeah. That rule remains same. If anything is more than 5 diopters, probably you need to.
Minus measures more and.
Minus measures more and hyperopia measures less. So.
Small amount of hypermetropia, small to moderate amount of hypermetropia generally masks the exotropia. So especially the intermittent exotropia. So if we have to plan and surgery, I prefer to give them correction, full correction with their spectacles so as to unmask how much ever divergence they have. So for us to assess the deviation properly before surgery.
Correct. In addition, let's not forget that astigmatism may be there. So if it's a plus astigmatism, it will be equally harmful. So, I mean, you need to correct it. So you may think it's a hyperopic astigmatism. That's not going to be helping the child in accommodating and making it better. So if there is an astigmatism, you need to correct it, even if it is like 1 diopter or 1.5 diopter.
Yeah, astigmatism is full correction, irrespective of what.
And whenever you're undercorrecting, the key thing is that the vision should not drop. So you undercorrect to the maximum or whatever you feel is tolerable, but the vision should not drop. Otherwise, your fusional vergence gets affected. So mild undercorrections or mild hyperopias, you could off the glasses. But again, without the glasses, check the vision. Just make sure that the vision is not dropping. Otherwise, you kind of lost the fusional vergence to try and gain accommodative vergence. So.
In some of the cases, this pre-op prism adaptation test might be useful.
How much importance you would give for assessing intermittent divergent squint for distance stereopsis? See, initially what happens in intermittent divergent squint, it is the distance stereopsis which is affected. And gradually as the eye diverges more and more, the near stereopsis also gets affected. We don't check the distance stereopsis always. And probably we don't check the near stereopsis either.
Which is wrong. That should be done. At least that should be done.
Yes, should.
And the equipments for distance stereopsis are not available at
Agreed. So the near stereopsis should never be missed. I would say whenever even a child 3+, we are able to do a TNO test. So any child is going to be cooperative and you can do the stereopsis testing for near. Whenever you feel that the near stereopsis has become, it should not be delayed for surgery. So you may be deferring the surgery sometimes because the mother is saying that more than 50% time is fusing. But if you find the stereopsis for near is deteriorating, it is a red flag. And you need to tell that, yes, we should do it.
At some stage, we may...
Near stereopsis is not a very good indicator of control as far as, because it is really retained for a very long time, even though control is...
No, but I see cases which are having poorer near stereopsis also. So we are getting cases which are deferred, and many a times there. The other thing which I find is that there are people who recommend alternate occlusion. Somehow I have not been a big fan of that unless there is associated amblyopia. If there is amblyopia associated, yes, treat the amblyopia by occlusion. But otherwise, in intermittent divergent squint, giving an alternate occlusion to my mind appears counterintuitive, that you are breaking the fusion for whatever hours you're using. Why do you want to do it? I would say that don't use this.
Unless you have an evidence of a small central scotoma during the time the patient is divergent, or I mean, if there is near stereopsis,
there is an amblyopia, yes. If there is
I mean,
any associated poor vision, then you are justified in doing occlusion for the reason for amblyopia, not for IDS.
Stereopsis, then obviously the patient is, when he's fused, he is having binocularity. As sir is saying, why would you want that to be lost? Why would you reduce the duration?
I would rather encourage them to do fusion. Yeah. And even small children, you can give convergence training, if not convergence exercises on machines. They can be asked to converge closer. That is something which can be, if you are waiting for 4 years or 5 years, in the meantime, you can do that.
Although a recent study has shown
they will be very happy to watch mobiles.
Basically, all these non-surgical modalities, they are temporary measures.
So I was alternate patching. I would say it probably has a small role in sometimes children who are 1.5 years. Yeah, those who are 1.5 years old, very difficult to measure, where you have to stand 6 feet apart to say, yes, squint is there. That kind of things. Probably if parents, I think it has some placebo effect on the.
But why would you want to alternate patch such a child whom you cannot even, confirm that you're going to have any benefit or side effect?
I can see the squint.
No,
why patch?
You
can't have an ostrich attitude of hiding the squint.
You patch to make sure that he breaks and he comes back a few months later, but definitely.
Somehow I think it's counterintuitive.
It doesn't. But I don't have any measurements. What do I do?
No, wait for that time that you can have measurement in the meantime.
So in
don't
that
patch.
Time,
don't make it worse.
If you do alternate patching, sometimes parents feel, yes, something is being done, doctor is on top of.
But that is, I think, I would, to my mind, it appears the obverse of what one should do.
So most studies are equivocal in their outcome. Even in older children, the studies that have compared patch versus no patch, they have shown it to be equivocal. I mean, I'm not sure any definitive advantage in older children where you can assess. So in younger children, I would be a little careful in advising anything, as just follow up.
I have a point. In infantile intermittent exotropia, sometimes one eye will be squinting more. Patients will complain that one eye is squinting more. And then it may be very difficult for us to assess the vision. The child will be too small. The assessment of vision also may not be very accurate. In that case, sometimes alternate occlusion we can give for a short time. That's what I do in a very small child.
If you're suspecting amblyopia, it is fine.
Yeah, if there is a preference, sir is already saying if there is a clear fixation preference, you probably should occlude the dominant eye only.
Don't make it worse.
Yeah. But in infantile ET, we give alternate occlusion. No?
Infantile esotropias, of course.
Totally different ballgame. Must.
And they are constant esotropes. So there is nothing that we can help them by making them fuse. So infantile esotropias, of course, alternate occlusion till the time we operate, maybe a month.
Thank you so much. Dr. Solin, can I leave? I have to go somewhere.
So thank you so much. We have a lot of congratulatory messages on YouTube and Facebook, and I would thank everyone for their presentation today. Dr. Manoj, I would hand over him for a small vote of thanks. Thank you.
It has been a very sort of a enriching experience for me as a comprehensive ophthalmologist to be present and hearing you all speak about the pediatric subspecialty. So on behalf of AIOS headquarters, it is my present privilege to propose a vote of thanks. At the outset, I would like to thank Dr. Pradeep Sharma sir for chairing this session. And my congenial thanks to Dr. Savleen for being the expert moderator today. And we had a galaxy of speakers today, right from Dr. Ramesh Kekunaya, Dr. Ankita Bisani, Dr. Sumita Agarkar, Dr. Jitendra Jethani, Dr. Pradeep Sharma sir himself, and Dr. Subhash Dadeya. And my congenial thanks also to the expert panel, Dr. Santhan Gopal, Dr. Pramod Kumar Pandey, Dr. Shubhangi Bhave, Dr. Elizabeth Joseph, and last but not the least, Dr. Rohit Saxena. So thank you all for this wonderful session on pediatric ophthalmology.